Hey everybody, today we're going to talk about hypertension. My name is Victoria Krejci Kitchell, and I have a master's degree in the science of nursing and some postgrad work in nursing and healthcare education. I'm a registered nurse, certified emergency nurse, and certified as a flight nurse. So when we talk about hypertension, there's two different types. There's primary hypertension and secondary hypertension. The other name for primary hypertension is essential hypertension, and really that means that it does not have a specific cause. There are definitely risk factors, however, that lead to primary hypertension. Secondary hypertension affects all ages. Here you can have infants, children, adolescents, and adults having secondary hypertension. But it's incredibly rare to have essential hypertension in infants and children. Now we are seeing more essential primary hypertension in older children and adolescents. Because of these risk factors, we're seeing more and more children with obesity and having a pretty significant sedentary lifestyle when they're sitting in front of the game console anytime that they're not in school. And when they're in school, they're sitting a fair amount of time as well, and they may or may not be participating in physical education and recess. And so we're seeing poor diet in those kids as well, and sometimes it develops into a metabolic syndrome even. But generally, primary hypertension is seen in adults, and secondary hypertension can be seen in all ages. The other big risk factor we're talking about when it comes to primary hypertension is smoking. We see a lot of problem with that. And so that's going to be one of the number one risk factors that we can talk to our patients about. Okay, when it comes to secondary hypertension, I talked about the fact that it is secondary to another specific cause. And there's a number of reasons for that. Excuse me. It could be substances like over-the-counter medications, prescription medications, illicit drugs like cocaine, toxic chemicals such as lead. Lead poisoning can lead to hypertension. And foods, of course, really salty foods, and that kind of ties into diets. But there actually are some foods that have a side effect of secondary hypertension. Lima beans is one of them, which I thought was really interesting when I was reviewing for this presentation. The other big thing, though, is pathological causes of secondary hypertension, and there's a list of those. They could be renal, for example, artery stenosis or renal failure, polycystic kidney disease, glomerular nephritis, or nephrosclerosis can be involved. And so this is where the patient actually has the renal problem first, and that develops into hypertension. Also, when you think about cardiovascular causes, that could be coarctation of the aorta. Tumors, there's a whole list of tumors actually. Pheochromocytoma, cytoma, neuroblastoma, Wilms tumor, adenocarcinoma. So these are affecting the renal system, but they're tumors to begin with. Endocrine hyperthyroidism, that one is big. We see a lot of hyperthyroidism, especially in the area where I live. Though we don't 100% know why that is, something in the water, we joke, but that actually could be legitimate because we do have high levels of arsenic. And so there's some research going on here in the area, actually looking at, is there something in the water that is leading to hyperthyroidism? Other endocrine issues can be Cushing's disease or hyperaldosteronism. Neurologic problems, Guillain-Barré syndrome. I think that's kind of interesting as someone's struggling with Guillain-Barré. They tend to have secondary hypertension. And increased intracranial pressure. We will definitely see secondary hypertension. And often that's because the hypertension is trying to overcome the intracranial pressure in order to continue to perfuse the brain effectively. This may or may not be effective, but you're going to see hypertensive issues in that case. Hypertension and atherosclerosis. I want to take a moment and hit on this because this is a really big deal. We see these in conjunction with one another on a regular basis, and there are a lot of outcomes, very poor outcomes with this combination. And so this is one thing that we want to focus on when we're talking to our patients and doing patient teaching is, it's really easy to say, if you don't take care of this, you're going to die. Well, patients really blow that off and they think nurses are being kind of melodramatic and it's not that big of a deal. And well, it is a big deal. And it's important for patients to understand the specific things that are going to go wrong with the combination of hypertension and atherosclerosis, especially if these two problems are not managed. And in most of the time, I find that my patients, take it a little more seriously when I say things like, you're going to go blind. You won't be able to see. And they're like, what? Because, especially if they already have a sedentary lifestyle, what do? They watch TV and they read. Well, what if we take that away from them? Then there's going to be, some bigger consequences. And so I like to explain the details of that when you combine hypertension, which damages the blood vessels way at the far end of the capillary beds, where we need them, and damaging them is not good. And then atherosclerosis, where we make it so that there's not a really good blood supply to those distal blood vessels and capillary beds anyway, and that tissue is going to die. And so explaining that, and then, for example, in your retina, and then when that goes bad and that retina dies, there's nothing left for you to be able to see with. And so you will ultimately go blind. And so that's a good thing to focus on. When we're talking about the heart and the arteries, we're talking about increased myocardial work, increased pressure, and a decreased flow. That can lead to left ventricular hypertrophy because that left ventricle is just working so much harder to overcome all of the decreased flow out in the periphery. We can have aneurysms, heart failure, stable angina. We're actually stressing the heart to the point that it's having pain. Go all the way to acute coronary syndrome and unstable angina, to obviously a myocardial infarction and having a heart attack. When we're getting into the kidneys, we're talking a little bit more about the failure of autoregulation because we're damaging the capillary beds, and that's where there's, it's very pressure sensitive in the kidneys, and the kidneys react to that pressure by giving us, that's a huge system, so we're not going to get into the RAS system today, the renin-angiotensin system, but if we damage those pressure sensors, then the kidneys don't auto-regulate the blood pressure anymore. And so we're going to have more and more problems there. That's going to lead to possibly bleeding and ischemia of the kidneys, and they're going to atrophy. They're not going to work as well. And ultimately, we're going to lead to renal failure. So now we have patients who've had a heart attack and they're on dialysis. The next thing is when we talk about the brain, we're going to have all this increased pressure and decreased flow. So we're at high risk for hemorrhagic stroke and ischemic strokes as well. And with the eyes, retinal detachment, retinal hemorrhage, and blindness. So now we have blind people sitting in the dialysis chair who've had a heart attack and don't have any energy. This is not a really fun way to live your life. And so this is where we really want to try to connect with our patients and have these conversations, not in a threatening way. Of course, we're not going to cause them harm, but if we can engage them to say, oh, really and truly, so if I stop smoking and I lose just 10 pounds, I can make a difference. Yes, absolutely. You can make a huge difference. All right, so what are we going to do? What are we going to teach these patients? The JNC is a giant committee that meets, I think they meet every 10 years. I was going to double check that and I forgot. And they look at what is the latest and greatest and how do we treat hypertension. And this is an international committee, and they present this information around the world. So we're going to focus on adults here. Pediatrics is a specialty of its own. And so basically what I'm going to do is I'm going to run through this algorithm of what do we need to do, and what you're going to see as a nurse with your patients who have either primary or secondary hypertension. At this point, it doesn't matter which one came first. We need to treat the hypertension. If it's secondary hypertension, then the primary problem also needs to be treated as well. And that's a separate discussion because it depends on what that problem is. So the bottom line is setting goals. We want to set a blood pressure goal, and we'd like that to be, it's age-based, but we'd like it to be reasonable. And patients should aim for that on a daily basis or on a regular basis. So when we go down this list, I'm going to start over on the left. We're talking about general population. They have no other real pre-existing conditions, especially diabetes or chronic kidney disease. If they're over the age of 60 years old, then a good blood pressure goal is 150/90. Note that's a little bit higher than everybody else's. And if you want to lower it, that's okay too. If they're sitting right at that 150/90, you can definitely lower it. But when you're over the age of 60, there's a little more room to work. And so that's what JNC has come up with. If you're under the age of 60, then the blood pressure goal is less than 140/90. Then as we progress down, the race comes into play here. It is really common for Blacks to have more issues with hypertension, and they react a little bit differently to some of the medications. And so that actually plays a part here. And we want to make sure that we are effectively dealing with our diverse populations. And so it's really important that we recognize that their treatment is a little bit different, and we want it to be more appropriate. And so that's highlighted here. If you're not Black, you're going to get on thiazide diuretics, excuse me, ACE inhibitors, angiotensin II receptor blockers, or calcium channel blockers, and either alone or in combination. And what tends to happen is you start with one drug. A lot of times they'll start with the thiazide diuretic first and see how that works. Give that 3 months, see what's going on, make sure that it's not totally upsetting the electrolyte balance in your patient, and see if are we getting to our blood pressure goal. If not, then definitely we're going to start another drug, And so then they'll add the ACE inhibitor or the angiotensin II receptor blockers or a calcium channel blocker. Now, some of that decision making on the physician part or the advanced practice provider part is what are other comorbidities that play into that. And so that's how they'll choose which medication is going to be most appropriate. If our patient is Black, they're going to start with the thiazide diuretics and then add calcium channel blockers. They may add other medications as well, but you should be seeing your Black patients on, if there's not managing their blood pressure with one medication, with the diuretic, then you should see them on calcium channel blockers as well. So have we reached our goal? Yes or no? All right, no. We really need to reinforce lifestyle adherence. And of course, that's the very first thing. It's way up at the top. I didn't even mention it because I think it's really obvious, but at the same time, it could be fixed. A lot of patients would just like a medication. Just give me a pill and make it all better. But that's not how things work. We really need to reinforce lifestyle changes and adhering to that, and truly it only takes 10-20 pounds to make a difference. So when it comes to weight loss, we don't have to have our patients lose all 50 pounds right away. Maybe they need to lose 50, maybe they need to lose 100, but if we can just start with 10 or 20 and then work through that little by little. Okay, also, if we haven't met our goals, and we're going to review all of that, the lifestyle changes, and see what we can do and what we can't do, excuse me, then it's time to titrate medications. And this is where you're going to call the physician and say, hey, I know my patient is on, the max dose of hydrochlorothiazide. They're also on lisinopril, and we're not meeting our blood pressure goals. Week after week if we're in home health, or day after day after day if we're in the hospital, and just remind the provider that we need to do something different. They're going to max those out. They're going to add a medication. They might change a medication and go from there. All right, let's go back to the top, because here we're just playing with medications and reinforcing lifestyle changes until we get our goal, hopefully. So if your patient is diabetic and they have no kidney disease, our blood pressure goal is less than 140/90. And then all ages, all races who already have kidney disease with or without diabetes, our blood pressure goal is still going to be less than 140/90. But we're going to change up the medications just a little bit. The more kidney disease, the more we're going to have to attack this, because it's going to lead to, stage 4 chronic kidney failure if we're not careful. So they're going to jump right in on starting ACE inhibitors and angiotensin II receptor blockers, alone or in combination, and they may go from there. But again, we're still going after the lifestyle changes, stopping smoking, getting control of the blood sugar and the lipids, eating more healthy, lower salt. That's a hard one. Sodas, moderate alcohol consumption, lower salt, and then increasing physical activity. Even if you get 10 minutes of physical activity out of your patient, 2 days a week, you're making progress over 0. So it doesn't have to go from nothing to moderate to vigorous 3 to 4 times a week, 40 minutes per session. Definitely you can start slow and build up. All right. Get to the last slide here. What did I do? There it is. Okay, so we talked about compelling indications or other problems when your provider is deciding which medications to be giving. You're looking at this blue section in the top left-hand side, and this was kind of wise to, if you're interested, to actually print it out, laminate it, and stick it in your pocket. But if you have a patient with heart failure, or they've had an MI, and we know they have coronary artery disease, they're diabetic, chronic kidney disease, they've had recurrent strokes, or they happen to be pregnant and they're having issues with their hypertension, secondary hypertension because of pregnancy. This includes the treatment choice to give you some ideas of what that patient might be on. What I liked about this screen also is that down below it talks about the things to look for. So you have the medication itself that you're likely to see, but then what do you monitor for, and nursing interventions. And so it's really important to watch with diuretics, to watch the electrolyte imbalance. Make sure that they're not getting hypokalemic. With ACE inhibitors, you can develop a cough and angioedema. That's really important. And hyperkalemia. Beta blockers can be really rough on people with asthma who are beta dependent with their inhalers. And they can have asthma attacks that won't break, and that can be pretty dangerous. Calcium channel blockers, you can have an increased edema, especially in the legs. And so one of the best things to do for these patients is to put them in compression hose and get them a little more active. Now, some people are like, yeah, but it hurts and they're so swollen. But if you can, when you're sitting down, lay back, put your feet up in the air, and when you're up walking, to actually walk with some purpose. They may need to get different shoes to be comfortable and safe, or non-skid socks, but then compression stockings also will help with them. The vasodilators, you may end up with a little bit of tachycardia, fluid retention, so that's something to watch out for. Alpha blockers can cause orthostatic hypotension, and of course beta blockers can as well, so you want to watch for that. And then your biggest teaching is going to be to make sure that when they go from lying to sitting and sitting to standing, that they take a moment and they keep themselves safe. You're going to spend a lot of time teaching about safety. There's clonidine, some other methyl-dopa, other medications that you're going to see down here centrally acting. And clonidine is fantastic for resistant hypertension where they just can't get a hold of it. They may have a clonidine patch on. And I don't see that super often, but especially with patients who've had issues with hypertensive crisis in the past, where they just can't get that hypertension under control and they're at high risk for stroke. And so those patients I will see with clonidine patches in place. All right, there's my spiel on hypertension. I hope this was helpful. If you have any questions or comments, I look forward to hearing from you, and I hope you have a great day.